but I'm sure those of you who do it should go with this particular. Buy that small, it's worth that investment, believe me.
Yeah, and the hockey stick, the design is such that your hand is away. So since there's an angle between the footprint, so when you're holding it, the vision becomes really nice as compared to the other L12 probes which the ultrasound people use. Your hand just comes over the probe and then your vision gets obliterated when you're putting an axis. So hockey stick is the is the best, but yeah, any L12 probe is fine.
And we can see the sheath
So
moving in. So how far are we?
Yes, when we were having nice discussion, I have taken my sheath because we need to go fast. We have a lot of things to show.
Yeah. Anil, carry on, please.
So
what is your plan?
The plan is to take a sheath injection. I have not done any aortogram. Sheath injection, and to see the size, echo size is around 4. So we'll see the duct anatomy and then take a call.
Okay.
Can we go to the lateral view because we are ready to move in? Echo wise it looked 4 millimeter with little short ampulla, but it looked decent one. Can I get a contrast? Can you? Hey, where were you removed?
So sheath injection karna.
Why you removed?
Anil,
So
eyes everywhere. You have to keep your eyes everywhere, Anil.
I know, sorry. Before I could realize. Because for sheath injection, the mandatory
Dr.
criteria
Suresh first talk was to know your personal as well. So you have to know who is around you.
I know. That's why great operators are always great. They see everything. So I have come up to duct and then I'm going to inject. So I am going to give a sheath injection. So it is almost occluding, little more than the size. This is a 6 French Malin sheath.
Would you not want to draw the sheath a little bit and then do a good injection? It will visualize the PDA better.
Okay. Okay, we'll give another injection. So, second injection. So, pressure on line, yes. So, echo measurement is 4. Here it is 6 French sheath, which is little high. 6-4 device or 8-6 device. What is the opinion from the house?
Definitely.
6'4", I mean,
Small child.
but 6'4" is for a 4 millimeter PDA, as you're saying, would be not a good choice.
8.6 is a good
touch
choice.
and go.
It's not touch and go. I would
8.6
not even
is a good choice.
think of it. Dr. Dalvi wants to say something.
Okay.
The only thing I wanted to
Yes,
say was
Dr.
that
Dalvi.
the echo picture that you have frozen doesn't seem to be 4 millimeters to my eyes.
It looks small. Could we have the
It looks
remeasure?
smaller, But since angiographically I won't be comfortable since you're crossed with a sheath, always some element of spasm and other things. So I would, if I am doing this kind of an angiogram, I would go solely by what my echocardiographer tells me. Because this is good for giving you a rough this things, but not the best.
Yeah, we also usually
I think size is
decide the size by doing the echo. We have already pre-decided, it just gives you a landmark where you want to place the device.
correct.
Sizing after crossing
I
can
agree
be
that
difficult. It can give
I
really mislead you.
completely agree, sir.
I think you go by what your echo said and
So
then
basically, yes. I am going by the echo. Dr. Shiva measured 4 millimeter. So here I am getting a good guide by angio. So we are taking a 8/6 device and let's see how it goes. So okay, 8/6 life tech device. So I am now taking the sheath in and taking wire out. Pressure on line 6. Load getting.
Yeah. लोडिंग को क्या बाउल किसमें लेना है इसमें बाउल कहाँ है
Okay. Get the cable. Six by six it will take.
नॉर्मल
Should take. Load. So Priya is loading the device.
सर मैं लेफ्ट हैंड से लोड करूँगी
Ladies have hand preference for a lot of things.
Till such time they are loading the device, why don't you ask the audience how many will go for 6x4 and how many will go by for 8x6?
Yes, sir.
yeah, and
I
do,
think it is a.
I think we can take that
great
poll,
thing.
but yeah, how many would go for 6/4 device?
फ्लश
Fair number, I
Fair
guess.
numbers, and 6/8. They far outnumber than 6/4. Sir, can I ask you one thing, sir? Dr.
The
Dalvi, sir?
expandability of PDA, nobody knows.
Why are you
If the echo
planning
is
for
showing 4
6/4
millimeter,
device?
then definitely a bigger device has to be taken.
Just one point. One place where we avoided the arterial axis. Looking at the ampulla, the chance of an 8/6 device including its aorta is high. There is a very poor ampulla in this. With that 4 millimeter, I
Sir, आया
agree
क्या
that you
फिर?
can't avoid using an 8/6 device. So I just
टिप पे
wonder
लेके आते
whether this was a case where a regular aortogram would have given us more
टिप लेके
information than the sheet.
But if
We wanted to prevent.
sir, what is Dr. Dalvi, sir? What is your point in favor of 6/4? Just the size of the baby or the size of the ampulla?
No, I feel that as Suresh very rightly said, my feeling is that the ampulla is very small.
5 French चाहिए
Getting
sheet है
the device into the ampulla will be impossible. So most of the device will remain in the aorta. That is my
Sir,
concern.
5 में
So if we see the aortogram here, I mean, if we would have kept just a catheter in the fluoros image and measured the ampulla, I think the ampulla looks a decent size too.
But you think that 8x6 with
Yeah,
the
that's
retention
the
disc
size of the
almost-
ampulla. Can you-
Almost 12
yeah, that's-
millimeters.
PA pressure was 20.
Yeah, so that is the reason why I feel that this is a smaller ductus and probably 8x6 might protrude
We have
into the
taken 8/6.
aortic lumen. That's my guess.
Overestimated on eco.
But the amount of the flow after the sheath into the PA
I
just
don't deny
suggests that this PDA is not small.
I don't
Crowd
deny
wanted
that, but I would put a 6x4, see how good it is, and then go ahead. If it is not good enough, 8x6.
So as we have loaded,
So the length of the device, again the same issues.
air is there.
As the length of the
Yeah.
the length of the
I am
PDA
seeing
is
some
small.
air. While loading, possibly some air.
It is not properly dared. You have to take
So
out.
I am taking. No. We dehydrate.
Yes, sir. Please
we-
go on.
In this lateral view, the ampulla is not profiled. Maybe in an RIO it will profile better.
Yeah.
ampulla should not be judged solely by one view. It may be added
Sister, please flash.
abundantly, sufficiently sized. 8.6 will hold well.
That is another alternate view that we can do.
I want to make one point.
Yeah, Ritesh, carry on, please.
As we can see on the angiogram and on the echo, the length of the PDA is small. So the narrowest portion of the PDA comes very, very early after the ampulla. So if we take 6-4 device, the bigger portion of the device is going to fit at the narrowest portion of the waist rather than the 4 mm. So I also feel that 6-4 would be the device of choice.
Point taken. Let's see. There was some problem when they were loading the device. There was some, as you can notice on the screen, there was air in the system, so they're pulling it back and reloading it. Most of the time, what we usually do is we measure the ampulla on the echo itself. So we try to measure the ampulla from the arch view and try to have a wild guess how much maximum size of the, because most of the sizing when we are using the venous access is done by echo. The size of the duct, the size of the device that we want to implant is usually done by the echo.
Can you please show us the echo again, the color picture?
Anil, they want to see the echo again. Can you, Anil, can you hear us?
I think Lakshmi is there. Yes, I am getting you, Lakshmi.
Can you show the color image, running color image of the echo?
Record it.
Come on. Flush. Flush, flush, flush. सर गंदा पानी है सर. अच्छे पानी से फ्लश करें. वहाँ है क्या पीछे पानी? Just keep playing those images, no? You played?
Could you have this colored
No, you just
Doppler
need to
images, please?
Play the previous ones.
Color Doppler.
The images which we had already taken, no? Can you just show those?
Can I make a comment?
Please carry on.
You,
We are just,
can you press the remote?
Predominantly, most of the times when we're doing PDA closures,
The
West,
color
we
images.
do take arterial access, but
Color with
talking to
color,
some of the people over here, majority of you guys don't take arterial access. I find it very difficult
you
to
see those?
believe that once you cross the duct with
Yeah.
such a
With
big
color?
sheath, the anatomy to me is completely distorted. I cannot base any judgment based on this angiograms after you've got a big sheath through. I would have, if I'm doing a case by just doing a venous access, I would just put a
So
catheter process rather than a big sheath into an angiogram.
Yeah, that's what I was discussing before I was interrupted. Primarily, all the sizing of the duct and the device that we are going to use, we do it before, prior to get us ourselves a rough estimate what device we are going to put. Then we put a catheter, do an angiogram with the catheter. Subsequently, if we are not able to visualize the duct properly, we do a sheath injection. Anil here probably bypassed that particular step in that particular this time. But most of the imaging that we do, most of the decision regarding what device size we want to put in, what is the size of the duct, it's primarily done prior to, based on the echo itself.
correct. Can we have that fluoro also, because we don't have a
Fairly
record?
good size PDA. This is 4 millimeter PDA.
Dr. Rajat,
Yeah, Anil, please carry on. We don't see the fluoro, so we are just seeing the echo. So can you just switch on to the fluoro?
Fluoro. So I have taken the 8.6 and just trying to deploy. So the thing is, I have deployed it and I'll inject in the arterial side for a levo phase injection to see how far I am
You
from
can,
the aortic clearance.
You can do the echo, no, Anil. It will be easier.
Now it is 13.
Echo.
You can just do the echo and see the
Echo.
arch.
No, one, because I'm in lateral view, I'm using that opportunity. Then we'll show in echo also.
Hare Krishna.
So now I have shown in the lateral view,
AP.
the liver phase is showing
AP.
there is decent arch flow. In echo we'll see better. Now arch, please show arch. Can you please put color there? So, LPA, we are seeing the arch flow looks decent. Only thing, when we release the device can go a little forward and cause some sort of more obstruction to the arch. LPA flow looks very good. So what is the opinion, sir?
Release.
So
Anil,
all agree with
Anil
that?
Muthu here. Anil.
Yes, please tell Dr. Muthu. Yes.
I think there's some turbulence in the arch because of the head of the device sitting there. When you release it, how it's going to sit in the arch is going to be a question here. Unless we know what's the grain across it, we can't release the device. So, and you can see that initially started off that ampulla is very shallow. In this situation, usually what I do is I prefer an occlusive device over a amplatzer or ADO 1 type device because the disc doesn't come in the aorta. So a 6/8 occlutech will sit nicely in this without causing obstruction to the aorta. It may be fine after releasing it, but my concern is you got a lot of pull on the device. Once you release it, whether it get into the aorta or not, I don't know.
Dr. Anil, just
Anil didn't listen to you, he's already released it.
yeah, but I think this device is like too much ballooned out, if you say so. It's too much ballooned.
Yeah, we agree.
Can we have an echo again?
Yeah.
There was no movement of the device, thankfully, Anil.
That echo will show a good echo images. PA view. Inject. Okay. 1 second. Come on. Show. We cannot show. Show. Echo show. I pulled it out. Show echo. Please.
Width less. Decrease the width. Put color
Color, please.
and compare. Color box vertical.
So now I think
Color
Priya
box,
is
increase the
showing the
length.
echo.
Increase the length.
Arch flow looks good with some turbulence. But that should not
Anil.
get away.
Anil, Dr. Suresh here.
Yes, please.
Don't say that arch
Yes,
flow
please
looks
tell.
good. There is turbulence. You may get away with it over a period of time. Hopefully it might settle. But it leaves us uncomfortable when we are sending this patient out to the lab.
We have a Doppler on that arch.
I think the
Yeah,
Doppler.
please Doppler.
Yeah, please. Proximal and continuous, both. A pulse wave before and then a continuous along the device.
Freeze. Increase the scale so that.
This is CW.
13 is the gradient. Yes. I think that the point is having validity both that when we put a device in a small child, one size small may not give zone of comfort and bigger will give trouble.
Vertically increase करो ना. Color box get it down.
the
So
problem,
that
Anil,
whenever we take a small child, yes,
see, Anil, the problem is,
yes, sir.
the predictability of the outcome. It is
Yes,
that
sir.
you may get away with this turbulence because it's not a very significant turbulence. Flow looks okay, but definitely the disc is jutting into the aortic lumen. And the whole issue is that
Yes,
when
sir.
you are on cable, we are never able to kick out, even if you have a catheter in the aorta, no gradient across ascending, descending, because of the recoil once you release it. And by that time it is too late. So we have been telling the companies to come out with guide wire, to come out with cables, which will show you the final position before release. And there are various ways of doing
You want to
it.
take a gradient here?
Although they are trying on it, but I don't think that currently we have
Scales
anything in the
increase.
market worth its promotion. And I think
Bigger.
that would be the
Accuracy.
real test of the thing. That once you have a cable, which doesn't give the recoil but gives you the last final.
Personally, I think if I was doing this, I would want to have if the device was sitting like this, I would be comfortable having a catheter in the aorta and take a RAO view before I actually release the device. Not having an arterial access, yes, it has its advantages because you may not have a pulse loss, but I would feel certainly
Gain
that I want an RAO before I let the child go.
focus.
Okay,
I have a
Anil, we'll leave you
question,
there. We'll move on to the talks.
Okay, okay.
Thank you. It was a nice case.